Welcome back to Lecture 7 and Part 2 on our series on grant writing, and specifically grant writing for our Africa program. It's critical that you see Lecture 7 before this one, otherwise you really won't be able to understand this presentation. Now, as we left Lecture 7, we had talked about that our organization had won a major grant award, and that grant award for child maternal health then was seen as revolutionary. So what we're going to do now is look at first a little bit of the history of our organization. Then we're going to take a quick look at why child maternal health is so critically important. And then we're going to go into what we've actually done in Kenya over the last 18 years. So if we look at our history as an organization, I first went to these set of villages, some 500 plus villages, in 1987 to do a health needs assessment. And the current project did actually not start until the year 2000. And in the year 2000, Dr. Gajera Mugambi, the CEO of our organization, my good friend and so longtime colleague, who was born in this village, basically the major village Chagoria, was born in extreme poverty, was able to come to the United States as a teenager to get his education here, was able to go through UCLA Law School, pass the bar in California, become an attorney in California, and lived there for many, many years. And to give up all that and to return now to this set of village to run these projects. So I had met him initially in the mid-'80s. This project started in 2000 when basically he and I and 12 village women started the current project of Village Hope Corps International. So 12 poor village women and $5,000 at a time when the village was having very, very difficult problems with the HIV epidemic before the anti-HIV epidemic medicines had arrived. And we had a very small start, but a very, obviously, one that would become very important to that village. So 18 years later, we went from the two of us, Dr. Mugambi and myself, to now 50 employees, 28 full-time employees in the health department alone. Our budget started with $5,000 in the year 2000. It now is approaching this year for $900,000. And those who we service, which started out as 12 poor village women, is now over 100,000 women and children. So we have had a very successful 18 years. It's taken a while, but we've developed deep community roots. We've never had a deep funding pocket. We've had to find multiple sources of funding, and that's one of our strengths because over the years, at least 6 foundations have continued to stay with us and funded us and increased their funding, and it points to the validity of what we're doing. So we have focused, our healthcare program in Hope Corps focuses on child maternal health. And my whole history, starting before I went into medicine, has been on child maternal health. And for 23 years of my life, I did hospital internal medicine and ICU internal medicine while I did global health along the side. And for the last 20 years, have been able to consult and teach just in global health. And the reason that child maternal health is so important is that if you look at the health of any society, but particularly now in the developing world, is that the basic unit is a healthy woman delivering and raising a healthy child. Because if you get that right, you end up with a healthy society. That is, you end up with healthy women raising healthy boys and healthy girls who then become parents of their own. So the most the most basic biological unit in global health is the mother and the child. And so focusing the attention there then reaps you great returns 15, 20 years down the line. And that's exactly what we've done. So our child maternal health program then breaks up child maternal health into 4 segments. Now we take care of what we are doing is to take care of a mother from the time she conceives to the time that her child leaves the school system. So that can frequently be 18 years. If that child goes through secondary school, that can be 18 years that we will follow that mother and child. Now, we're going to break up that 18 years in four important parts. The first part is infant maternal health, and that really goes from when a woman knows that she becomes pregnant, which is about usually 6 months before delivery, through delivery, and the first year of her child's life. So that's about 18 months of the initial infant child maternal health program. Then the mother and child graduate into the preschool mother and child program, which then goes from, let's say, 1 year of age until 5 years of age, when that child will enter our school system. Then we have a school mobile health program that focuses on school child maternal health, which will then focus on the mother from the years of kindergarten through what would be the equivalent of 8th grade in the United States. And finally, the adolescence program, which really starts, adolescence in this case being defined as the period of time between puberty and adulthood, which really in Kenya then would be that our 6th, 7th, and 8th graders, most of them then fall into that category, and also the 4-year of high school. So that is our adolescent child and maternal health program. So let's begin and look at the school-based, the school child maternal health programs, which is where we started. So approximately 6 years ago, we started a very innovative program where we partnered with the Ministry of Education. And in that partnership, they allowed us to come into their schools and use their own schools to teach health and to deliver preventative and curative services within the school system of 50,000 students. And as far as we know, according to the Ministry of Education, in this massive educational system of Kenya with 12 million school children, we're the only ones that have been able to do that. And at least in a school system with 200 schools and doing it with all the schools. What did we do? Well, first, when we go into the school system, when we first entered these schools, there was basically zero health education. So what we do is we come to the elementary schools and the secondary schools one time a term. Now, in Kenya, students go to school for 3 months, off a month, back to school for 3 months, off another month. So 3 times a year, we visit the schools and we provide health education, age appropriate, with an actual laptop, an LCD projector. Only 20% of our schools have electricity, so we bring our own kerosene generator, and we do in classroom health education with a skilled, trained educator for these students. So that is very, very important. Along with that, we bring our nurses who work as nurse practitioners, and they offer curative services to any sick child or any sick teacher in the program. And then with that, we have been a leader in then bringing preventative services into the schools. According to the Ministry of Education, we were the first nonprofit to bring treated drinking water systems into all 200 schools. So we have a treated drinking water system in all 200 schools that affects all 50,000 students. Now, before we did that, we tested the water in all these schools, or at least, in 22 schools, and all of them tested fecally contaminated. So the ability then to bring clean, treated drinking water to these children is extremely important. And with that, we also brought hand washing stations with soap, which none of the schools had when we first arrived. And we again think, or I've been told, that this is a historic first in Kenya, and so important. And these are really human dignity interventions. In 2018, every child, even children in the developing world, it's a human dignity issue that they can drink water that's not fecally contaminated, and that they can wash their hands after using the toilet facilities. And this is what you would want for your children, your brothers and sisters, and your grandchildren. And it's very inexpensive. We can provide clean drinking water in 200 schools to these children for about the equivalent of 3 cents US per month, and the soap at about the same level. So basically, if you look at 5 to 6 cents US per month per school children, you can provide them with soap and clean drinking water. And so that is at a cost where Kenya could even do that now without any further funding. Very important intervention. And again, apparently historic, according to the Ministry of Education, that we were the first to do it. And I think a very large part of why we won that major grant competition from ADEO.org. The other thing we've done is we've added malaria bed nets, because malaria is an issue in our area. Malaria bed nets to every entering student in kindergarten with an education presentation, not only to the child, who is obviously only 5 years old, but to the parents of the importance of keeping that child under a bed net and putting the brothers and sisters as well under the bed net. And these new bed nets work for 5 years. That again has been historic. We've done it with all the elementary schools and continue to try to do that, and that's been supported by the Giving Hands Foundation out of Germany for many years, who has helped us with our malaria prevention program. And malaria incidence has significantly fallen in our area, and we have placed now over 20,000 new 5-year treated bed nets into our communities, not only in the schools, but other with women and families who have worked in other part of our program. By far and away, nobody in our area has come close to the 20,000 nets that we've put into the community, in which we still do. So that program then has matured over the last 6 years and has been extremely successful. And you'll see that has been noted in a formal letter from the Ministry of Health, which I'll read to you later. So what grew out of that, though, as we knew right from the beginning, that if you just take care of school children, of course, then you're missing their mothers and their siblings, the preschool children. So after a number of years of partnership with the Ministry of Education, we were granted permission by the Ministry of Education for a partnership where we do our school mobile health clinic, both our teaching, our curative service, and all our preventive things in the morning in the school, and in the afternoon, any mother with any preschool child who would go to that school then comes to receive our services in the afternoon. So we're basically using the school facilities then to deliver school child maternal health in the morning, and then preschool child and maternal health in the afternoon. This is extremely efficient since we have no brick and mortar costs. And again, our teams stay in the field. Our nurses are there to treat any sick preschool children, on mothers, to counsel the mothers in family planning, to deliver services like growth monitoring, like vitamin A supplementation, family planning services, as well as dealing with any acute illnesses. And that's been extremely effective within the school system, and they have supported us greatly. So that program then morphs, the preschool program morphs into the adolescent and maternal health program. And really this picks up when a child is usually in 6th or 7th grade and goes through when the child leaves the school system. Now in Kenya, not all children go to secondary school, but if they do, we follow them and the mother until they leave secondary school. And again, the same type of things. Preventative services, the clean water, the hand washing, the educational services, and obviously things are age appropriate. What you tell a 6th, 7th, and 8-year-old is different what you tell a 12 or 13-year-old, which is different than what you tell a 14 and 15-year-old. I think that in our adolescent and child and maternal health programs, we look heavily at what affects the child. Certainly, there is HIV in this area. It's something they have to be warned about. There's certainly malaria. There's intestinal infections. As they get older, unintended pregnancy and unwanted pregnancy becomes very important, as this is definitely a problem in our area. And also as they get into the junior and senior years of secondary school, which we call high school, we look at them as mothers to be. and we actually talk to them about how you raise a child, about clean water, about hygiene in the home, about the use of soap, about the importance of breastfeeding, about the importance of child spacing, of the importance of considering your own fertility. And one of the key points of our program is that we've always combined fertility control modalities with mortality control modalities. And this is very important because, as we said before, 1987, when I first got there, 18 million people. And in the year 2050, there is going to be 80 to 90 million people in Kenya. So we need to do more than just reduce mortality. We have to be cognizant of what's going to go on in 2050 as far as the cost of delivering medical care, the number of patients involved, as well as food security, water security, and other issues. Now, the last part of this is a key program, and that is our infant maternal program. And that is the one program that we have not yet started on purpose. And this is why we're looking for this grant, because that turns out to be extremely critical program. And I did not want to start that. We could have started it, but I did not want to start it until I had really enough funding to do that program correctly. So if you look at a mother from when she conceives to when her child then, let's say, leaves secondary school at 18 years of age, the most critical part of those 18 years are basically an 18th month period from the time a woman knows that she's pregnant to the time that her child is 1 year of age. And that is our infant maternal program. So what we would basically do is, and our program is well designed, is that we will enroll a woman as soon as she knows she becomes pregnant. And basically all the women, since they're in these school systems and they either have their own children already in there or their brothers or sisters have children, they all know about us, that we enroll a woman as soon as she becomes pregnant. We then begin to follow her and give her education, how to raise a child, how to be or raise a child in a healthy fashion, how to be a good mother before she delivers, that we follow her closely. And then as we enter what I call the red zone, which is the 1 month before delivery, the actual delivery time, and the 1 month of the first month of a child's life. So that basically 2 months period then becomes the most critical period in all of the 18 years. And I think is well known, maternal mortality, the highest rates in the world are in Africa. In Kenya, it's about 500 women die per 100,000. And many of the children die with them, or because they've lost their mother, then have a very difficult time in their first few years of life. So this is absolutely critical. So we do have our community health workers in the field. We would start a program that a woman then is enrolled in our program. We begin to make home visits as she approaches 1 month before delivery. If she does not have a cell phone, and in this area many people have a cell phone, or at least their extended family does, then we actually give them a cell phone that they can borrow, which they will later return to us, and that they keep that cell phone during the month prior to delivery, through delivery, and then in the 1 month after delivery, as we begin to follow them up, both doing home visits with our community health workers, and also at times daily phone calls, just to be sure that mother or child is doing well. And when they enter the birthing unit, whatever the mother chooses, then we will work with them to be their advocates so that they get good care and then good follow-up as soon as they go home, that they're immediately seen by our community health workers, that they have their phone, that they are set up to call us at any time. So what we've also done, and this started with the school mobile health program and moved right on through with the preschool maternal health program, is that we've created, the only one in our area, a free health advice line. So this is a way that 24 hours a day they can call us and talk to one of our nurses, because we're only in the schools a certain amount of time every term, obviously. But at 3 o'clock in the morning, if they have a child with a fever or severe diarrhea or some other problem, they can pick up their phone, call us for free. They will get one of our nurses, and they will get medical advice. And then the next day, depending on the severity, they will either get a follow-up phone call or a follow-up visit